Alrighty, hey everyone, we're going to go ahead and get started today, take advantage of the hour we have together. Thank you all so much for joining us. I'm Sindhu, current Emory IM Chief Medical Resident based at Emory University Hospital. It has been my pleasure to plan this spring's resident-run CPC. Our goal today is to work together to solve a challenging case submitted by our resident presenter. We have also solicited the input of a few expert discussants who I will introduce along the way. You may see a few of them on the call already. I think we have a lot to learn from their authentic and notably their blinded input on today's case. So today's case, without further ado, is going to be presented by Dr. Anjuli Shah. Anjuli is a current PGY1 internal medicine resident in our program. She is interested in nephrology and she's from Buffalo, New York. She is going to kick us off today with this patient's presentation. So over to you, Anjuli.
All right. Thank you, Sindhu, so much. Thanks, everyone, for having me. I'll just jump right in. So for our resident CPC conference, let's talk about our case. So I'll present with you, this is our 77-year-old. She presents with a subacute progressive dyspnea with acute worsening in the past week. So basically for the last 2 months, she had slowly progressive shortness of breath. And then 4 days before she presented, she went from dyspnea on exertion to dyspnea at rest. Other things on review of systems is she has lower extremity edema, and she also has exertional chest discomfort. The rest of the review of systems was negative. So her past medical history. So she has a history of HFpEF, ejection fraction around 50 to 55%, with grade 2 diastolic dysfunction. She's on torsemide 20 at home. She takes it every single day. She also has coronary artery disease. She had multiple PCIs in the past. She's on aspirin, Plavix, and statin. She has CKD4 with a baseline creatinine around 2.2. She also has diabetes type 2, recently on insulin with an A1C about 6.4%. She also has a history of sickle cell trait. All right, so jumping to our objective data. So starting with vitals. So she came in afebrile, regular rate, normal tensive. Her respiratory rate was around 20 and she was satting 96 on room air. So more on her physical exam. So we'll start with mental status. She's in no acute distress. She's ANO ×4. Cardiovascular wise, so JVP was regular. It was around 8 centimeters. She had a regular rate and rhythm. No murmurs were heard on auscultation. All right, on lung exam, so she had a normal work of breathing on room air. It was noted she had bibasal crackles. So abdomen, soft, non-tender, non-distended. And then finally, she had 2+ pitting edema to the knees bilaterally. All right, more objective data. We'll jump into labs. All right, so in terms of her labs, I've highlighted some of the abnormal ones in red, but I'll talk about them. So she is anemic. She has a hemoglobin of 8.7. On recent admissions over the last 2 years, her baseline has been around 8 to 10. In terms of her chemistries, she has a BUN of 77, a creatinine at 3.32. Just to remind everyone, her baseline's around 2.2. Her glucose is elevated as well. She comes in with a BNP elevated around 1300. Her troponins were elevated and uptrended from 191 to 222. She had a mildly elevated PT and INR as well. And then on the rest of the CMP, she had an elevated ALK Phos at 130. The rest of her LFTs were within normal limits. All right, some imaging for her. So we got a chest x-ray and take a look at that for a second. This was the read. So no pneumothorax. Her lungs were mostly clear. She has a trace right pleural effusion. Her cardiomediastinal silhouette is within normal limits and stable from others in her previous admissions, and there was no osseous abnormalities. All right, I'll move on to her EKG. So I'll keep that up for a second so everyone can take a look. And then I'll put up the read. So she's in sinus rhythm. She had some PACs, a left bundle branch block, no ST wave changes concerning for new ischemia at this time. All right, so then I'll jump into her hospital course. So first day, she is admitted with concern for CHF exacerbation. At this time, we were doing IV diuresis. And on day 2, her volume status has improved with about 200 milligrams of IV Lasix twice a day. However, she still has dyspnea at rest. Because of that troponin elevation that she came in with, we did do a cardiac PET, and it was negative for new ischemia. So as we are working up her acute decompensated heart failure, on day 6, she has melena. She also has hematochezia later on during the day, and she was noted to have a hemoglobin drop from her baseline admit at around 8.7 to 6.8. She required 2 units of packed red blood cells. And on day 7, we consulted GI.
All right. So thanks, Anjuli. At this point, we're going to turn it over to our GI expert, Dr. Jason Brown. Dr. Brown is originally from New Orleans and a graduate of the University of Georgia. He is currently an assistant professor in the Division of Digestive Diseases and practices general GI at Grady. Thanks for joining us, Dr. Brown.
There we go. Thanks for having me despite my inability to work Zoom after all this time. Can you see my slides? Excellent. So this is what I'm hearing as I'm going through the case. This is my version of the problem representation. 77-year-old female, heart failure, coronary artery disease, CKD3, suspected CHF exacerbation, being diuresed, but having persistent shortness of breath. Now with new onset melena and hematochezia and a transfusion-dependent anemia. So when we get this consult, we're thinking this is a consult for melena and hematochezia. This is kind of perplexing. It's unusual to have both. It happens, but it happens infrequently. Assuming the melena is actually melena. I sound like a GI fellow, I must, when I'm challenging that, but that's always a question that we'll ask. But this sort of watch and wait approach to what's going to happen with this bleed is being exhausted. This bleed's not going away. And while it may not have driven the initial admission, it's here now and it's driving the hospitalization and it's a barrier to discharge. So we have to deal with it. So I don't really know what's going on with the melena and hematochezia, but we got to solve this. So let's get moving. When we think about an approach to GI bleed, we're asking ourselves 3 main questions to help characterize the bleed. Where is it coming from? What's coming out and how much? And how sick is the patient? And they each have their own differential diagnoses. And then when you put them together, the diagnoses can shift and change a little bit as well. So you have to weave them all together. They're interrelated. And it's okay to think about them separately, and we'll go through that, but eventually you have to synthesize all that. So the first is location. And one quick and dirty way is, all right, is it coming from above or is it coming from below? And conventional wisdom would tell you that the location should intuitively indicate the diagnosis, and that should direct your endoscopy, what you select. Is it an upper GI bleed coming from above, an EGD? Is it a lower GI bleed coming from below? Nice and simple, but we all know that we've dealt with small bowel bleeds, previously called occult or obscure bleeds. So what do we do with that? We've all seen melena come from above, but we've also seen potentially melena come from below. So how do we sort of move beyond that? Anatomic location to us has some very clear meanings. So an upper GI bleed, which represents about 50% of all GI bleeds, is from the upper esophageal sphincter to the ligament of Treitz. 10% of GI bleeds are small bowel bleeds, ligament of Treitz to the terminal ileum. And terminal ileum to the anal canal represent lower GI bleeds, which are about 40%. Now, unless you have a CTA or a tag red blood cell scan, you rarely know the precise location of the bleed. So we have to lean on some other information. This presenting symptom can be a surrogate, and sometimes we use it that way. But the problem is, although melena is considered an upper symptom, again, we see this from small bowel sources. We see this from proximal or right side of the colon sources. Bright red blood per rectum is literally per rectum, but we can also see this with upper GI bleed if brisk enough. So this, as with any schema, really is not reliable on its own, and you have to use multiple different pieces of information in context. So what about the output? How about matching the output or the symptom the patient reports to you, or the sign that you see with the degree of bleeding? Classically, if I were to ask everybody on this call to close their eyes and envision hematemesis, you're probably envisioning bright red, something pretty large volume. But the truth is it can include coffee ground emesis. And for those keeping track at home, you can get coffee ground emesis with only 10 cc's of bleeding. For melena, like we see in this case, it can come from as little as 50 to 100 cc's of bleeding. And it can pass up to 96 hours after the event. Now, 90% of melena does indicate an upper GI bleed, but 10% of the time it's coming from somewhere else. In bright red blood per rectum, we oftentimes will think about an anal, rectal, or distal source, but 11% of the time it's coming from an upper source. And oftentimes, if you're getting enough bleeding from an upper source to show bright red blood per rectum, you're losing at least 1,000 cc's of blood. So by differential, hematemesis makes me think of anything all the way from varices and doulofoy lesions and large ulcers to maybe Mallory-Weiss tears or esophagitis. This is not an exhaustive list, but as you can see, hematemesis is along a range and it makes you think of different things. Melena is where it gets a little bit more confusing. It can also present like varices, particularly sentinel bleeds, also Mallory-Weiss, or something smaller volume like esophagitis. Ulcers or Cameron's lesions inside hiatal hernias, AVMs, we see this a lot with, and malignancy. And bright red blood per rectum obviously makes you think of more distal sources, AVMs, diverticular, ischemic disease, IBD, hemorrhoids, infectious, or like we talked about, upper GI bleeds. Acuity is another factor to help weigh. And for us, chronic generally means weeks to months. The patient has some semblance of stability, and generally we're working that up as an outpatient. Acute generally means hours to days. The patient's clinically stable-ish, but it's an inpatient workup, and this patient falls sort of in that area. And then we also will think of hyperacute, which is bleeds that are fast, minutes to hours. They have shock physiology, these patients. They're definitely inpatients. And that can afford its own differential. So chronic, we're thinking about malignancy, polyps, things that would give you iron deficiency anemia, like AVMs, inflammatory bowel disease. Acute tends to be higher volume things, so ulcer disease, diverticular disease. Again, AVMs can bleed fast or slow, just depends on how many, where they are, and how big they are. Ischemic colitis can bleed pretty quickly as well. Hyperacute tends to be really life-threatening, very fast, very brisk etiologies, varices, big ulcers, aortoenteric fistulas, doulofoy lesions, things like that. So we also have to take a measured approach to endoscopy. So as proceduralists, to scope or not to scope is not so cut and dry. Oftentimes we get a call and there's a consult for X endoscopy. We're calling because we want a colonoscopy. We're calling because we want an EGD. But just because there's an indication doesn't mean it's an automatic pass to the GI lab. There are two huge, sometimes invisible aspects to our medical decision-making. The first is patient candidacy. So that can manifest as ASA classification. So how sick is the patient on an anesthesia scale? And that can dictate level of sedation. So is it moderate, MAC, general anesthesia? Location of the endoscopy, can we bring them down to the GI lab? Does it need to be done in the ER or the ICU? Logistics, is the patient capable of being transported? Are they able to take a bowel prep? Can we get a pre-op assessment done? Do we post, if we're going to post for two cases, EGD and colonoscopy together, can we post them in tandem or should we split them up? And that comes with its own set of sort of risks and benefits. The other piece of this is that the risks and benefits of proceeding with a procedure are very real, especially for those of us who've been around long enough to see patients decompensate during a procedure. They have to be weighed very carefully with the patient and their next of kin. Is the procedure diagnostic? Is it therapeutic? Is bleeding driving the clinical course? Or is it present but sort of in the passenger seat and something else is driving the clinical course? And will the risk of doing this and potentially harming the patient or even killing the patient dramatically change the course of this hospitalization and the course of this patient's life? These are all things that we have to accept and think about as proceduralists as we're weighing the indications. So when I hear this case, there's some key features that I think of. The shortness of breath and volume overload could indicate CHF, but I always think about cirrhosis, particularly decompensated cirrhosis, since those patients are so sick. So any little clue that could tip me off that maybe there's undiagnosed cirrhosis going on, I like to look for and be aware of. And could this be hepatopulmonary syndrome or portopulmonary hypertension masquerading? The patient was on a statin, did have diabetes. Maybe they had undiagnosed NASH cirrhosis. What speaks against that are the platelets were 200, the INR was 1.26. The JVP, the lack of hepatic encephalopathy, were also somewhat reassuring. CKD, whenever I hear that, or end-stage renal disease, particularly on dialysis, I think about AVMs and uremic platelet dysfunction. Anticoagulation, antiplatelet agents are always something that I'm thinking about. The baby aspirin's not really so much of a factor here. We could pretty much do anything diagnostic or therapeutic on that, but the clopidogrel is of interest. Thankfully, this patient's not having shock physiology, so we do have some time to think about stuff and bowel prep if that's what we want to do. The BUN to creatinine ratio is a little bit lower, so I'm not so much thinking about upper GI bleed. But then there are cardiac comorbidities. So if we're going to pre-op this patient and transfuse to goal, what is that goal? Is it 7, like we say for everybody? Is it 8 or 9, like we sometimes say for cardiac or patients with strokes? And again, I would, just looking at this and hearing it right now, rate the ASA as a 3, maybe even a 4, just depends on the anesthesiologist and their pre-op assessment, which impacts what we're able to do for them. So the differential diagnosis at this point for me would be, it's still pretty wide open, but I'm thinking about AVMs. This feels somewhat classic for that. There's off and on bleeding. There's the right comorbidities. There's sort of a chronic anemia picture. There's the right degree of bleeding. AVMs can present, depending upon if they're bleeding fast or slow in that particular moment, as melena or hematochezia. Right-sided diverticular bleeding is also definitely possible. Because maybe it bled on the right side real quick, and then you got some melena from that, but then it bled very fast, and that presented as the hematochezia. Less likely to be an upper GI source. If it was, it would have to be one of the brisk ones, right, to get red blood per rectum. So maybe it was a Dulafoy or varicose or ulcer, but it's probably not. I'm leaning more towards AVMs and right-sided diverticular bleeding. Now, for me to select what type of procedure, I'm thinking the vitals are stable. We have time to prep. So let's do a colonoscopy, and then sometimes we'll list it as plus minus EGD, so that if the colonoscopy is totally negative, we flip the patient around and do an EGD. But if we found someone on the colonoscopy, maybe we can save them the EGD and the time under anesthesia. But I'll do her with monitored anesthesia care because the differential's lower GI bleed heavy, and we have the time to set it up. Now, per ASGE 2016 guidelines, we would continue the baby aspirin. And if it's not within the first 30 days of a PCI with intervention, we can hold the clopidogrel, because remember, this is a diagnostic procedure we're going to do. It may convert to therapeutic. Diagnostic endoscopy is lower risk for bleeding, but endoscopic hemostasis is considered higher risk, so it is a consideration of ours. Now we'll throw it back to the case.
All right. All right, thank you so much, Dr. Brown, for all of your comments. That's extremely helpful. Wish you were with us during our case. So I will give everyone a little more data. All right, so let's go to our hospital course again. So because of that Plavix washout period that we had, on day 13, a patient got a colonoscopy and an EGD in tandem, one after another. I'll show you some of those results. So let's talk about the EGD first. So patient had normal esophagus. There was a few sessile fundus gland polyps without any bleeding. There was some localized mild inflammation of the gastric antrum and a normal examined duodenum. I'm sorry, the pictures are a little blurry, but I've chosen 2 from the gastric body and the gastric fundus just to show those polyps and some of that mild inflammation. All right, next I will talk about the colonoscopy. So there's a couple findings here. So there were some non-thrombosed external hemorrhoids, and at the bottom of my slide, you can see some non-bleeding internal hemorrhoids as well. Interestingly enough, throughout the colon, there was blood throughout. However, there was no identifiable active bleeding. There was a 26 millimeter cecal polyp, and it was not amenable to resection during the colonoscopy. There was also a few small polyps in the ascending colon as well. And there was some diverticulosis in the sigmoid colon. And let's take a look at some of these pictures. So things that I'd like to point out, you can see some of that blood throughout. You can see that carpet-shaped polyp on the cecum on slide 4, as well as some polyps on the ascending colon in 5, 6, and 7. And even as you look down towards the slides, you can just see some blood throughout. All right, I am going to invite Dr. Brown back to talk about what he thinks.
Absolutely. All right. So the EGD, these were pretty common findings, none of which are significant sources of bleeding. So the hiatal hernia is noted, that's associated with reflux, but there's no Cameron's lesions, which would make you think of iron deficiency, anemia, or bleeding. Those are essentially ulcers inside of hiatal hernias. The fundus gland polyps are benign, often associated with anti-acid therapy. They don't really bleed. Quote unquote gastritis, if we're going to extrapolate and use a term that's, although from a histopath perspective, perhaps not the best one to use, one that we commonly use, but the gastritis itself is generally not going to bleed to the degree that you would see bright red blood in the colon. The colonoscopy, you're right, is very interesting. So the first thing that I think about is that the terminal ileum was clean. There's no blood in the terminal ileum. It doesn't look like it's coming down from the GI tract. So that makes me actually think, and it's not perfect, but it makes me think this is a colon-centered bleed, perhaps. Now, the internal and external hemorrhoids are noted, and they can bleed, but they don't bleed like this, and they don't reflux bright red blood all the way back to the cecum. And you could appreciate in that cecal picture, there's bright red blood and a fair bit of it. Hemorrhoids don't bleed like that. Polyps can definitely bleed. Sorry for the typo there, and particularly on dual antiplatelet therapy, but generally that tends to present as more of a chronic type bleed. It's very rare to see almost 2 units in an acute setting, especially in somebody on stable dual antiplatelet therapy. So that leaves us with, well, there was some left-sided diverticula. Diverticula were certainly on our differential, but it was right-sided, and these were left-sided. Sometimes we have seen left-sided diverticulosis bleed quickly and reflux red blood all the way back. And maybe that blood sat there, got a little digested, and came out as melena. Hard to tell, but not so clear, unfortunately. So in this situation, a lot of times we're asked, or we will think ourselves, should we take a second look? And first of all, I just wanted to define those terms as they are in the textbook, perhaps maybe not how we use them in common practice, but a second look EGD is a relook within 16 to 24 hours of treating a lesion that you diagnosed or finding one with high-risk stigmata. So typically, if you take that definition and apply it to this case, there wasn't an ulcer that we found, there wasn't a doulofoy that we found, there wasn't an area that we couldn't really clear and see very well. So second look is not typically applied in this scenario, although if the patient continues to bleed, all bets are off. Second look colonoscopy is even more of a rare term. It's an uncommon entity. It's rarely defined in the literature, most of the time in relationship to positive fit. And you did a scope and you didn't find anything. So there's a question, should we take a second look? Also, IBD patients that are inpatient that are not getting better on steroids, wondering whether or not you should triage this to failure to respond to steroids and colectomy or some other therapy, or whether or not there's some other thing going on. But a lot of times we will use the term second look. And in fact, it's starting to show up in some of our guidelines. So the ACG has a relatively recent guideline on small bowel bleeding, which I thought really applied very specifically to this case. So second look upper endoscopy should be considered in cases of recurrent hematemesis, melena, or a previously incomplete exam. And second look colonoscopy should be considered in the setting of recurrent hematochezia, or if a lower source is suspected. And if those are normal, point number 3, the next step would be a small bowel evaluation, because 10% of these bleeds can come from the small bowel. And as we said, melena and hematochezia can both come from small bowel sources potentially. Push enteroscopy is where we take a pediatric colonoscope and we advance it as far as we can go, kind of like an EGD, but with more length to look at a longer portion of the duodenum and even proximal jejunum. And that can be subbed out for an EGD if you have a high threat or a high pretest probability that AVMs, small bowel AVMs, are present. or if the patient has a history of that. And then video capsule endoscopy would be a first-line procedure that we would order for looking at the small bowel. So at this point, if she stopped and she didn't bleed anymore, didn't require any more blood transfusions, we may say, a lot of people may say, well, maybe this was diverticular bleeding. Let's move on and hope it doesn't happen again. But if she continued, you'd really be forced. And a lot of us would probably do either an EGD push enteroscopy with another colonoscopy. And if those were negative, again, maybe proceed with a video capsule endoscopy. So I'll hand it right back.
All right, thank you so much again.
Absolutely.
So I will jump back into the case for yet again more data. So back to the hospital course. So like we said, there was no clear source of bleed identified. And this is someone who was transfusion dependent anemia, especially in the hospital. And with her age and her condition, we really wanted to get that resolved. So at this point, we did have a referral to colorectal surgery because the appearance of that polyp, there was some presumed possible idea that that could be the reason she was bleeding. So on day 15, she underwent an ascending lap colectomy. And, you know, we thought this is the end of it. But on day 17, she had both melena and hematochezia. And, you know, at this point, we agree we wanted to make sure this was melena, this was bright red blood per rectum, and it was. We all saw it. She did require an additional unit of blood at the same time. The last piece of information I'll give right now is actually earlier in her course, her AKI did progress to the point where she required renal replacement therapy. At this time.
Awesome. All right, so now we have our patient. She has undergone what the team had hoped to be a definitive management strategy for her bleed, but unfortunately continues to bleed pretty significantly. While it seems like a second look is certainly on the table, we'd like to invite our next expert, Dr. Craig Hoffmeister, who is a professor in the Department of Hematology and Oncology here at Emory, to help us think through undifferentiated persistent bleeding.
Hi, good afternoon. I don't have a lot of slides about this, and I'm not a huge fan of a ton of slides. But the idea in general for folks who have, from a hematology perspective, when you don't have a particular AVM that's upsetting you, a particular ulcer that you can't stop, and you're trying to look systemically, in general, try to do the basics again and again and again. So look at what the patient is taking. In this case, the patient had dual antiplatelet therapy with aspirin and Plavix. And think about the basics that you need to have adequate coagulation. So you need some platelets. Platelets are the phospholipid surface upon which most clots and coagulation factors are required. You need also to have lots of coagulation factors, and you want to look at their function. So you want to look at the intrinsic and extrinsic pathways with the PTINR and a PTT. Generally, going on to the thrombin time, et cetera, is usually overkill at the beginning. And if you're looking systemically, you just want to see, does the patient have platelets? Do they have a coagulation cascade that is functional? And are you doing anything to prevent those things from working adequately? This is the simplest way to start. If your coagulation cascade is abnormal, then moving forward to saying, hey, let's try to figure out, why is the coagulation cascade not functional? Are they missing a factor? Or is there potentially an antibody that stops the coagulation cascade? So this is a mixing study directed towards either the intrinsic or extrinsic pathway. And this is the next step when you find an abnormal PTINR or PTT. I'll pass it back to you.
Awesome, thank you. Thanks so much. So at this point in time, the team is kind of considering their next steps, sending some of this work up, and pathology from the patient's initial endoscopy returned during this time. Just out of interest, if anyone has a guess as to what it may have revealed, feel free to go ahead and drop it in the chat. In the meantime, I'm going to go ahead and turn it over to Dr. Erin Sohn, who is a GI and liver path fellow here at Emory, to walk us through these biopsy results.
Thank you for having me. So I'm going to show you the images of the stomach biopsy. Here on the first image, I have a low power view of the stomach, and it's the enteral mucosa because it's not a biopsy from the body or the fundus because we don't see any parietal cells or chief cells. So this is enteral mucosa, and unlike normal enteral mucosa, which perhaps this small focus would be more normal looking, we can see that there are some empty areas with some material that is pushing the crypts apart. So to better analyze this tissue, we go on to a higher power view, and we start seeing this amorphous eosinophilic material, and there are some lymphatics around the deposition as well. And this morphology is very suspicious for amyloidosis, and to confirm the diagnosis of amyloidosis, we have performed Congo red stain, which without the polarizer, it's supposed to show the salmon pink color. And the normal lamina propria uninvolved by amyloidosis would show this bluish green coloration instead of the salmon pink. And to further confirm amyloidosis, we use a polarizer, and it's now highlighting the apple green birefringence. So this confirms our suspicion based on the H&E slide. And this case was signed out as enteral mucosa involved by amyloid. I have a very quick slide, just this one single slide to bring some helpful points. And it is that we are familiar with amyloidosis involving the heart and the kidney, but amyloidosis can also involve the GI tract. And most commonly, it involves the small intestine, and less commonly, it involves the stomach. And as seen in the photo I've shown you before, it normally shows this homogeneous, waxy, mildly eosinophilic extracellular material. And seeing this sort of morphology is what prompts us to go ahead and order Congo red stain and look for that apple green birefringence on polarizer. And amyloidosis can have primary cause due to multiple myeloma or Waldenstrom macroglobulinemia, but it can also happen due to secondary causes such as dialysis associated or serum amyloid A associated due to chronic inflammatory disorder. But for both of those causes, morphology remains fairly similar. However, if there is amyloidosis, so much of it is going on that it's starting to form a mass or polyp, it's likely to be due to a primary cause. And as previously mentioned, Congo red stain is a stain that we like to use to confirm the diagnosis. And amyloidosis can involve the tissue heterogeneously. And in the case of random biopsy, the distribution may not be very obvious to us on a quick scan. And just to make sure that we don't miss any amyloidosis, if there's any clinical suspicion, it's very helpful if you let us know in the order requisition. And that's it. Thanks.
Awesome. Thank you so much. That was super helpful. So I'm sure a few of you kind of saw that coming. Maybe some of you didn't, like I did. So something I didn't reveal about Dr. Hoffmeister earlier, for those of you who don't know him, is that his practice focuses on plasma cell disorders. So I'm going to throw it back to him and see what he thinks about this presentation of amyloid, how it might be linked to our patient's GI bleeding, and what kind of additional workup he would recommend at this time.
Great. So to talk about amyloid, the case is interesting, right? Because the patient had HFpEF, but these really abnormal cardiac biomarkers that you wouldn't have expected given the patient's presentation. And there wasn't a lot of discussion about the patient's renal insufficiency and these really abnormal biomarkers. So seeing a lot of HFpEF or at least HFpEF that's not yet been connected to AL amyloid, you have to keep it in your mind's eye that the patient has amyloidosis as there are so many symptoms related to amyloid that can occur. Is it all right if I share my screen? Just a quick, there are two types of amyloid that come to mind in my view, and the one's AL amyloid and one's TTR amyloid. And the AL amyloid is related to generally light chains that are created by abnormal plasma cells in the bone marrow. And these light chains misfold and are deposited in various organs and cause organ dysfunction. TTR amyloid is from the TTR protein, helps carry thyroxine around the blood. This also then can misfold and get deposited in various organs and cause organ dysfunction. So when you think about them both, they both have proteins that are made, circulate in your blood, they misfold and they're deposited in organs and cause organ damage. One, the protein's made in the liver, the other, the protein is made by abnormal plasma cells in the bone marrow. And in neither case can we really suck up the amyloid fibrils that are damaging the organ. You're generally trying to remove the protein from the blood, either by decreasing the misfolding in TTR or in AL amyloid, you're trying to kill the plasma cells. But if you look at a lot of these symptoms here and what are both specific to AL amyloid and things that are shared between the two and things that can occur primarily in TTR, a lot of the times these symptoms are pretty common. Lumbar spinal stenosis is incredibly common. It wouldn't necessarily jump to think of that, but in these patients who have heart failure that's unexplained, sometimes renal failure that's unexplained, peripheral neuropathy, especially autonomic dysfunction. I'm sure there's somebody in Georgia that's not hypertensive, but I don't get to meet them unless they're an AL amyloid patient in my clinic. Polyneuropathy that can't be explained by 20 years of ignoring your diabetes. It should also make you think that there's something wrong with this patient's nerves. And to think about AL amyloidosis specifically, this is really where these light chains that are made by these plasma cells are causing a problem. And they're actually a sequence of disorders where the protein secreted by these cells is causing the patient harm. And so you can see this somewhat newly named monoclonal gammopathy of renal significance has these pathologic diagnoses from kidney biopsy. But you can see that acquired von Willebrand's disease, cold agglutinin disease, these light chains actually can cause coagulation abnormalities and predispose patients to bleed. These clusters of amyloid fibrils can show up in your intestines actually, and just their presence alone can lead to uncontrolled bleeding. And you really have what's the difference between AL amyloidosis and myeloma is that the AL amyloidosis, the protein secreted by the plasma cells is what's killing the patient. And in multiple myeloma, it's really the cells that are more actively trying to kill the patient. And so there are patients who have both myeloma, where the plasma cells themselves are chewing at their bones or filling up their bone marrow and actively trying to kill the patients from a cellular mechanism. But there are also patients with myeloma that can also have AL amyloidosis, where the protein secreted by these cells is forming these fibrils that on average you think of collecting in the kidney, in the heart, or in the nerves, causing significant dysfunction from there. Now, I'll stop here.
Thank you so much, Dr. Hoffmeister. Let me share my screen. So we can talk about the remainder of our patient's course. So, you're correct. I hid the fact that the renal side of this for the sake of our discussion, but as her workup for the GI bleed continued, we also had nephrology on board to investigate her progressive AKI. So she was found to have elevated free kappa light chains over 1,000. However, she was negative for paraproteins. When we got her biopsy results back, it was a very quick call to hematology. A bone marrow biopsy was done as well. And she also had a cardiac MRI to really investigate her HFpEF. And it was suggestive of myocardial fibrosis. All right. So for the rest of her course, she was started on Velcade, cyclophosphamide, and dexamethasone. She was actually briefly transitioned to the ICU for acute blood loss anemia. She did continue to bleed. She received an extra unit of blood. She also had tranexamic acid, vitamin K as well. Her bleeding improved over the next couple of days. And actually, by the time she was discharged, she had some renal recovery as well, and she was able to get off of dialysis. She was discharged home on day 30. She continues on VCD regimen. She was also started on another immunotherapy. And since then, I think she was discharged in early March, and she has not required hospitalization since. And she's actually doing quite well, which is so wonderful and so thankful that we got her treatment right away. So now I want to talk about my takeaways from a challenging case, especially diagnostically. So the first thing is when it feels like you're managing multiple different complications, taking a second to step back and tell that story from the beginning. Especially as a PGY1 and intern, we're managing things as they come. But being able to reframe her narratives was really important. Second thing is having a place, physical or virtual, where all of the consultants can talk together. I'm sure everyone here on the call can understand what it's like when you have one consultant doing something, another consultant, and they're coming in at different times. Having a place, whether that's on Epic or even in person, to discuss the case with multiple different minds can get everyone on the right page. Third thing I wanted to talk about was being okay with telling the patient and their family that we don't have all the answers. Being very upfront and honest, that can be kind of feel awkward for us. It doesn't feel comfortable as well. But actually, during this case, we were able to get a little more history. I went in to see the patient and said, we're not quite sure why you're bleeding and why some of your kidney function hasn't come back. Let's just talk about that a little bit. And we found out that she actually had an episode of melanoma last year that she didn't go to the hospital for. And so we were able to elicit a little more history from that. Final thing, my final takeaway is reflecting on the patient's clinical course once a treatment plan is finalized. So this is something we did after we found out this was amyloidosis, after she started treatment, is we took a step back to debrief with our team, saying, okay, what are some of the things diagnostically, treatment-wise, that we did well when she came in? And what are some of the things that we could have done differently when she came in? All right, so that is the end of my talk. I want to thank some people. So some of my co-interns, Dr. Trey Woods, he is actually the intern who admitted this patient before I took over. Could not have done it without his hard work, as well as Dr. Gabby Gunderman. So she was on the nephrology service during this case, talking to me every day saying, hey, I don't know, our team thinks there's something else going on. And then, of course, Dr. Melray D'Souza, old chief here. He was our cardiology fellow during this case. He was incredible being able to coordinate everything. Martina V, so she is one of the Atlanta GI PAs who was on the floor with us every day while our patient was bleeding, really coordinating care. And then, of course, Dr. Abayavis, she was our hematology attending. As soon as we got that information, she started therapy right away. She was on our phone. We were talking at night, in the morning, really getting this patient the best care possible. And then again, for this conference, thank you so much for letting me be a part of this learning exercise. Thank you so much to Sindhu for really planning everything. And then, of course, thank you so much to Dr. Fadke for advising us on this presentation. And then, of course, another round of applause to all of our consultants. Thank you so much for your expertise and sharing your thoughts. And then I will be open to any questions.
Yeah, happy to take any questions now if anyone wants to unmute or in the chat. And then if you have thoughts, comments, any feedback for us on how to make this better next time, please feel free to email me at the email address on the screen. Thank you to everyone.
Well, that was a really, really fantastic case and a fantastic discussion. Sorry if you can hear the drilling over my head. Thank you to our chiefs for putting this together. And also adding to the discussants, thanking the discussants. That was terrific.
I wanted to address one question in the chat, which came a little bit before, which was if the patient had significant proteinuria. So this was actually interesting. She did not have a ton of proteinuria. We usually think about amyloidosis being a more nephrotic range proteinuria. However, the proposed theory was that she had more deposits within her renal vasculature, more in the renal arteries and veins, which caused some of these symptoms.
All right. Well, I think, again, that's grand rounds for this week. We look forward to seeing you again. Or is next week actually not a grand rounds week? I think it's not, right? Yeah, grand rounds is not next week. And so we'll resume the week after that and look forward to seeing everybody then.